Hey, welcome back to the Joint Dynamics Intelligent Movement Series podcast. My name's Andrew Cox. I'm one of the owners and directors of a company in Hong Kong called Joint Dynamics. And I'm also the curator and host of the podcast. So let me ask you a couple of questions to pique your interest on this podcast episode. What does a morning erection have to do with heart disease? And if you're a dude, you go out drinking at night, why do you need to go to the toilet so often? Well, today's podcast guest is Colin Symmonds. Colin is also one of the owners and directors of Joint Dynamics. He's actually the CEO, ladies and gentlemen, and he's a physiotherapist with a special interest in men's health. To elaborate on all of the things to do with our prostate, our pelvic floor, our erections, and more, let's throw over to Colin Symmonds. Welcome to the podcast, Simo.
Morning. Thank you for having me.
This is our second time on the podcast.
It is. That was ages ago, the first one, wasn't it?
Great to have you back.
Gosh, and the podcast has really grown since those early days.
It's so fun, isn't it? And we're back at Monday Studios. Everyone, what a great place this is. Look at this place with all the cool stuff. Anyway, Colin, if you were to do an introduction to what you do in a men's health specific task when we're looking at it through the lens of physiotherapy, could you sort of elucidate what it is, how a physio that has an interest in men's health can help, and what you do?
Yeah, so it's very interesting, and it's a really nascent part of physiotherapy. So it's starting to grow, but it's about 20 years behind women's health. So women's health is all about pre and postnatal care, peri and menopause issues, sexual pain, things like that. So the women are much better at talking about their stuff, and they're much better at collaborating with other women or seeing their doctors about it. But what we found is that men's health was really not spoken about 20 years ago very much. Men were, just sucking it up really and just getting on with it. And so this new field of physiotherapy is really growing. And there's been some wonderful sort of pioneers in the industry. And what we found is that men need as much help as women do, simply because the things that afflict men are often embarrassing, and men won't talk about them, and they feel that they're alone because men traditionally don't share information with each other in the same way that women do. We're just not programmed to do that, and societal pressures also mean that we are less likely to want to talk about things because we need to appear a particular way that we've all grown up to with, believing that masculinity must depict itself in a certain direction. And so the physiotherapy aspect is no different from seeing a physio for your shoulder injury or your back injury. It's about a set of bones and muscles that work together that impact things like urinary and fecal continence and sexual function and kind of weird pains that develop if these things go wrong. And that we're recently just putting together a whole host of sort of symptoms and treatments that can be effective to help men. And what we're realizing is that men are much underserved in this area. And so we're finding that the stats we have for men are very, very skewed because people don't talk about it.
Yeah.
I mean, a man is much more likely to tell his mum that he has an erectile dysfunction than he is to tell his doctor. And so, we're not used to talking about stuff, but now we're trying to create forums and support groups and then interventions from a physiotherapy perspective that are really helpful for guys.
Just on that talking piece, a recent episode, I think it was 116 with Tim Baker. He wrote the book Patting the Shark. Mm-hmm. He's an Aussie surf journalist legend, and he was diagnosed with stage 4 prostate cancer, and it was metastatic, got into his bones. But anyway, he used to be the editor of a really famous surfing magazine called Tracks magazine in Australia. And we were just discussing it, and he said blokes would much rather write into a surfing magazine and ask about their sexual dysfunction or their sexual issues than they would to go to an actual doctor. So they had this page where men would write in and go, I've got something going on with my cock and nuts, quote to be an Australian, my penis. Can you help me? As opposed to, like you just touched on, it's hard to gather data when nobody's talking about it. You know what I mean? We're 20 years behind. I'm competitive, guys. We got to catch up.
And you won't talk to your friends because generally we men are so competitive with each other that no one wants to admit having any disability. Certainly in the sort of cock and nut department, really.
Quote,
quote,
thank you.
Unquote.
You touched on pioneers. Before we go any further, can you tell me some of the pioneers in this field?
There's a guy called Gerard Green, and there's a whole bunch of them from Australia as well that have moved into this area. There's some guys that have pioneered some of the transperineal ultrasound work that we do that have developed that. And there's just a whole host of them now, and they've worked really quietly in the background. Like there's a woman called Jo Milos, and she has sort of started a lot of work and research. The problem is that you don't get very far unless you get the researchers involved, because physiotherapy has traditionally had a whole bunch of treatments and interventions that we've used just generally that we found a little later on in life actually don't work the way we think we do, but we've had a consensus-based approach. So we really need the clinicians and the researchers to work together to find strategies for we give guys pelvic floor exercises, but do we give them 3 sets of 10? Do we give them 5 sets of 20? We just don't know. And no one's actually worked out the correct dosage of any of these things. And we all have we think it might be this, we think it might be that. And what we found is that we have to tailor it to everyone. All exercise has to be specific to the person that you're working with, but we can't really regulate how much that is because we just don't know, and nobody's researched it. So there are still lots of gaps in our knowledge at the moment. And the most important thing is that the patient gets better, or that the guy feels that he has some level of control over his continence, if that's what the problem is. And that we know if something's working or if it's not working because we can kind of see it. But really, we don't know how much to give somebody.
And those 2 courses you did just last year, it's 2025, everyone, Happy New Year. Those courses you did just recently where you went to Oregon, was it? Where'd you go?
So I went to Seattle, but there's a guy called the 4 horsemen of the male pelvic apocalypse. Something like that.
That's what we're going to talk about that in a minute.
But that was brilliant.
Horsemen.
That was a really brilliant course because it was actually developed by a orthopedic surgeon who is also a physio. And then I did another course from a physio practice in Brisbane, and they're sort of pioneering the way there. And some valuable stuff, but again, there's not much material out there, and we have to travel around the world to get any level of accreditation.
Not anymore. You're going to get it right here as best as we can, hey Simo?
Do my best.
Hey, let's dive into the anatomy first, so at least we have an understanding. Like, we used the scientific terms cock and nuts, but maybe that's scratching the surface, isn't it? Maybe we can go a little bit deeper when we're talking about male sexual health, and when we're talking about male pelvic floor, physical therapy, physiotherapy. Can you dive into the anatomy, prostate, all that sort of stuff? Can you just share that, and then we can move forward?
Really simply put, you've got your pelvis that sits sort of like the bony bit that your waist sits on top of, and there's 3 layers of muscles that are horizontally placed. They go basically between your tailbone and your pubic bone at the front, and they have various functions at different levels. The more superficial function is sort of the muscles that attach to the base of your penis, whose couple of functions is they have to restrict blood flow coming out of the penis so that you can keep an erection, and then another set of muscles that act as effectively a pump as well, that help you sort of finish off when you're peeing or help with ejaculation as well. And then the different levels work different areas. So most guys who, if we're going to be honest, we're very attached to our cock and nuts. And often what we do is we can move our penises without actually using our hands, and we can flick it up and down. And that's really that top level, the most superficial level of your pelvic floor working, because it has function in sort of sexual function as well. And then you've got the kind of middle layer, which actually helps, it moves your testicles up and down as well. So your testicles kind of move around at night actually to aerate themselves, a bit like something trying to cool itself on a barbecue. You kind of turn it over. And so if you ever get a chance,
have a mind of their own.
They do actually. And if you ever get into watch somebody's, they do kind of move and rotate and do stuff, because they really try and regulate their heat, because obviously they live outside the body. They don't like to be too hot. And then the lowest level of the pelvic floor is really about sort of bowel function. So the muscles that stop you from defecating, or the ones that kind of when you push out a stool, you need them to kind of relax and unkink the rectum so that you can go properly. So it's a finely tuned system that's really well connected with the nervous system and the hormonal system, and it has to all work together properly. And so you can see if any of these levels are having problems, of these pelvic floor levels, they're going to impact things like fecal and urinary incontinence, sexual function, and because there's a whole bunch of nerves that live in there as well, you can get some weird pelvic pain symptoms that we used to think were just part of prostatitis. But we now know that prostatitis, from a bacterial perspective, is only 5% of that pelvic pain, and the rest is to do with who knows what within the pelvis. So it can be kind of the prudental nerve, it can be sort of any of the sort of nerve bundles that sit inside can have problems, or it can be mediated as a spinal level as well.
Geez, there's some stuff going on there. And so then, just to finalise the anatomy part, we also have the prostate, the bladder, the urethra. You want to just touch on
the kind of in the pelvic, you've got the bladder that sits sort of quite squarely there, and your urethra that comes through it, and it also passes through the prostate, which is kind of a gland that is part muscle and sort of part hormonal gland, and the urethra passes through there, and the prostate gland, which is about the size of a walnut, job is to sort of store some of the semen and help to pump it out. And it creates an alkaline environment for the semen to come through. And because the vagina is an acidic environment, so it needs to protect itself. And then that passes through into the penis, and then you get to urinate that way.
Isn't that just the marvellous aspects of biology, when you just said the way that when we're making love, having sex, trying to inseminate someone for whatever purpose, the female and the male environments are just perfectly entwined to each other. And also, one thing I found fascinating when in ejaculation, there's the levels of zinc and the PSA, the prostate specific androgen, comes with the ejaculation as well. And then there's fructose. So our sperms are not on a ketogenic diet, ladies and gentlemen. They need some fructose in there to run up there and find their home, don't they?
It's random.
Important information. Okay, so where does it all go wrong? So we know that, especially with prostate cancer, the number one driving factor of prostate cancer is age.
Yep.
That's inevitable. Where else can it go wrong? And then we'll touch on all the things.
So there is so much. It's like any life cycle. So like you look at female life cycle, the women often have very predictable things happen to them within the sort of that pelvic health arena, so that they're going to eventually have a period, and then they're going to be fertile, and they're going to be going into perimenopause, then menopause, and that's quite predictable. But men, often it's referred to as andropause, but men just don't function like that. We don't have a set cascade of things that happen to us. Things can happen all the time, but there are certain ages where we're more likely for things to happen. So everyone assumes that all cancers are kind of when you're older, whereas things like testicular cancer, somewhere between 15 and 35 is when that will happen. And if you poll people, they will say 50s or 60s, because people don't know. So you have a cancer that's probably the easiest cancer to treat, with the highest success rate, that is often a problem because we've neglected to tell young men that they need to be checking themselves regularly. It's not like men aren't familiar with their nuts, really, is it? I mean, we spend a lot of time fondling them, and yet we could teach guys to make it much more useful that once a month in the shower, people can check themselves and then just go to the doctor if there are any anomalies. Then it's really easy to treat. And the likelihood that it's missed is usually because people just don't know what to look for, basically.
So that's the first takeaway, Simo. Geez, loading up already. Testicular cancer, what do? Just literally your testicles are hanging down in the shower. If it's hot, then they're hanging lower. Does that make it easier? If it's cold, cold shower in the morning, people, if you're checking your testicles.
They're going right inside.
Oh, no, I can't find them.
So what you would do is once a month, maybe the first of the month, just when you're in the shower, just soap your balls up and then just feel them. They've got to feel the same. So basically, they should be the same size on each side, although the left one usually hangs slightly lower. You've got some cords at the back which are normal. So they're like the spermatic cords, which look like this sort of zigzagging pathway of vesicles that you can feel up there. There should be no painful areas and there should be no hard areas. So obviously the balls are fairly spongy, but they've got some resistance to them, but they should not be painful. Balls should be exactly the same size. And they, when you shower off, they shouldn't be red or anything. They should just look the same as each other. And if you have any changes, that's when you need to go and see your doctor.
Done. Lock that one away. And now, okay, then
and also on top of that, talking to your kids as well is really important. That a father or mother, whoever, a caregiver, needs to help a young man understand that he needs to check himself regularly. And that's just part of what he does. Like women are taught how to do self-breast exams. Men just need to be looking at testicles.
Well, you said 15 to 35 is the highest prevalence of testicular cancer. That's when you get
it mostly, yeah.
Wow, okay. My boy's 14, Xavier Cox. Get involved.
It's an unfortunate name.
At that age, when boys are teenagers, they're self-examining a fair bit anyway, I imagine. So they might as well just drop around the shower and
exactly. They just need to be a bit more organised. And there's so many resources that we can link to kind of methods of self-examination and just talking about it and sort of demystifying it for guys. It's not a long process, and you just need to make sure that the left and the right are the same.
Got it. And so back to the pelvic floor muscles. I imagine in this life that we live, there's some things that would weaken the pelvic floor and there's some things that might strengthen the pelvic floor, and those might be indicative of where I am with my sexual health or my incontinence, whether it be urinary or bowel function.
The muscles behave in the same way as any muscle. They respond to stimulus to help them grow and to get stronger, and they get weakened by the same sort of things, sort of disuse, inactivity. Being overweight is probably one of the biggest causes of a weak pelvic floor, just because there is so much weight pushed onto the pelvic floor, because the pelvic floor function is also to support your internal organs. So you have ligaments inside that kind of keep everything in place, but they aren't hanging off them in the same way. The pelvic floor is supporting them. So the idea is that the pelvic floor has to be quite nicely active. And it's active, it's a posture, kind of set of postural muscles, really. So they do have some sort of versions where they kind of lift and they relax, but they should be sort of fairly active a lot of the time. But they shouldn't be over tight, or as we like to refer to it, as unrelaxing. So we used to say hypertonic, but really that's to do with kind of neurological conditions. So we say, an unrelaxing pelvic floor, one that is just too active all the time, has its own problems, because if you think about it, you're trying to allow blood to go into the penis, and if it's too tight, then it can't get enough blood in, so you end up with an erectile dysfunction that way. Or if it's too weak, it can't keep the blood in anyway, and so that you just can't maintain the erection. And also part of the kind of the ejaculation moment, those muscles on the base of the penis, whose job it is to help kind of pump out the semen, they have to be really strong to kind of get that going. When you're younger, what you notice is that your ejaculation travels a lot further, than when you're older. And that's because part of the function of the pelvic floor and the prostate as well. So, you want one that's it's like Goldilocks and the Three Bears. You want it to be just right, not too tight and not too loose.
So, paraphrasing, if you're inactive, a sedentary lifestyle will lead to weak muscles, full stop, including your pelvic floor, which can then lead to incontinence and sexual dysfunction. Overactive. How would someone get overactive pelvic floor muscles? By over-kegling all the time? Or how would
to be honest, there is a case to be said for people who are looking at online pelvic floor exercises and they're just doing them to death. And it's like basically just doing bicep curls every single day. Eventually you'll get a bicep that's just always switched on and it's too tight. And because it's too tight, it can't generate enough tension to do its job properly. And so it appears weak, when in fact it's just too tight. So we have, in younger guys, a lot of the pelvic floor issues can be caused by things like poor lifting techniques. So we have lots of young men that go in the gym and they're doing lots of strength training, which is absolutely vital for everyone, men and women, to do. But if you're bracing really hard, so like you're doing like a very, very heavy lift and you're bracing down instead of kind of pulling in, the pelvic floor is just going to be smashed all the time. So either it's going to respond by being over tight because it's having to fight all the time, or you just overpower it and you just weaken the crap out of it. For most younger men, this is a very broad statement. It tends to be a pelvic floor that's too tight, and as you get older, it's the pelvic floor that's too weak.
And also, breathing plays quite a role in toning or conditioning the pelvic floor.
It does, because as you breathe in, the pelvic floor should actually relax. So normally we think about when you breathe out, things should relax. So as you take a big breath in, and your diaphragm moves down, and then all the contents of your abdomen move down, the pelvic floor should relax and allow that to happen. And then when you breathe out, that pelvic floor should increase its tone, and everything should lift up again. So the diaphragm and the pelvic floor are effectively doing this together. And that when we're retraining the pelvic floor, you're really trying to link those two together, because breathing seems to trigger the correct action. So you know yourself as a trainer, that if people don't breathe properly, it causes all sorts of issues with how they activate their muscles. So if we can link the respiration with the pelvic floor activation, we find that we can get much better response, and people can kind of get it. Although it's slightly counterintuitive, because we assume that, when you're breathing out, everything should relax, but when you're breathing out, the pelvic floor is actually sort of contracting. We're not talking about massive contractions, but we're talking about an increased tension within the pelvic floor, pelvic bowl.
Well, on the lifting technique, one of the things that we talk about. Go on, mate. Hey, Wilson, what is this? I'm going to crack open this kombucha with Chinese herbal honey. Honey Digest. They're one of the sponsors. I'm going to have some, along with Mu Vitality, functional mushrooms. People, go to Mu Vitality.
I was hoping it was beer.
Mate, it's kombucha. We're health professionals, Simo.
Oh, yeah, that's true. I'd forgotten about that.
Oh, that's good. I love kombucha, by the way. Back to lifting. One of the things that we teach with lifting, and the importance of diaphragmatic breathing, as you just touched on, the diaphragm is this sort of two domes, isn't it? Bigger on the right side where your liver is, and a little bit smaller on the left side, and there's the central tendon in there that won't move very much. If it does, you're in big trouble, aren't you? Because your heart will disconnect. But as we breathe in, the diaphragm, let's make it one. The diaphragm descends down. As it's descending down, it takes what's below it, your quote-unquote your guts, your abdominal organs, and pushes down into the hammock, which is the pelvic floor. And that, in a lifting context, that pressure will precipitate counter pressure, and that will condense the abdominal organs, because your abdominal organs play a role in spine stability when you're lifting.
They do.
So correct, just because you touched on correct lifting technique is to use your diaphragm. If someone takes that big breath before a lift, and you might see it, they'll go, and they lift their chest like that. I'm like, whoa, that is not correct lifting technique. Correct lifting technique is get that diaphragm down to compress the organs against the pelvic floor to make almost a rigid sac for your spine to press against. So that's one of the things that is so important that we can extrapolate across all areas of health is proper breathing technique. And that not only plays its role in pelvic floor health, overall health, but also in lifting health. Lifting health. And that's a new term. Come to Joint Dynamics for your lifting health, people. Thank you. And so then when you speak about the prostate, so we have the bladder, the urethra goes through the muscular organ that is the prostate. The seminal vesicles sit on top of it there, and the urethra flows out through the penis, where the urine and the semen comes out of.
Yep.
Let's just dive into a second. Prostate cancer, or you said prostatitis, inflammation of the prostate.
So there are effectively
that,
three conditions that we talk about with the prostate. Well, there are probably more.
Bloody good stuff.
Are you enjoying that? The first one is sort of an enlargement of the prostate, sort of a benign enlargement, which is not cancerous, but occurs in most guys as we get older. And usually there's not a problem with it unless it starts to encroach on the urethra, and then you find that you're having difficulty peeing, and you're not completely emptying, because the funnel, the urethra that it goes through, is kind of squeezing, so that it's actually being blocked. So it takes you a long time to empty your bladder, and you'll go to the doctor, and they'll find that actually this is it's not a problem, it's not cancerous, it's just enlarged, and that most men when they die will die with an enlarged prostate. I mean, there is a sort of saying that says that all men die with prostate cancer, but it doesn't mean that you die from it. It's just as once we sort of die, everyone seems to sort of have an enlarged or a precancerous sort of prostate as well. This is happens much later in life. But when you're younger, you get a couple of conditions which we used to refer to as prostatitis, but probably it's better to call them chronic pelvic pain syndrome. And what would happen is you'd come in with some weird pelvic pains. We wouldn't know what it was. And usually there is only a 5% of that group of people where it's bacterial. And so the best thing to do is actually have your doctor take a urine sample, milk your prostate so that the bacteria comes out into the urine, and they'll sample it and they'll grow a culture and they'll tell you exactly what bacteria it is, and then they can give you the right antibiotics. The interesting fact is only 5% of prostatitis is bacterial, but 70% of patients will be given antibiotics routinely.
Really?
Yeah. And we know that that's just not helpful. But often, urologists don't have much choice but to do that, because they're like, well, let's just see. And then you'll do one course of antibiotics and it won't make a difference. Then they'll put you on a longer course of antibiotics. Or if things just don't get better, they'll just keep trying different antibiotics because it seems to be the only solution. But also, the prostate's quite deep inside. And even with bacterial prostatitis, it can be really hard for the antibiotics to get there. But the other 95% have this chronic prostatitis, which is really this chronic pelvic pain syndrome, which can hit in your 40s, 30s and 40s in guys. That's when it's more prevalent. So that's more prevalent early on. And that gives you just a bizarre set of symptoms where you have pelvic pain, where you feel like you're sitting on a golf ball in your perineum, so just behind your balls, you feel that that's just full. Or you get these weird penile pains where you get maybe the left side of your penis hurts after you have intercourse. And then it's trying to work out what's causing that. And so we know that that's going to be mediated either by the pelvic floor muscles themselves or the nerves around the pelvic floor, particularly for things like if you have cyclists who cycle, and it's particularly common if you cycle for more than 14 hours, you end up putting a lot of pressure through your...
A day, a week, a month?
So it's these long distances, like if you go out for a day and you're cycling for 14 hours, you're much more likely to get these pudendal nerve or pudendal neuralgias, where that saddle just keeps poking you, and you basically compress the nerve to such an extent that it sort of starts to break down, and it has to then regenerate. So you know that one of my patients had 2 weeks of basically just having a numb penis. Because
as a result of
cycling,
this quote unquote excessive whatever.
Yes, but I think also volume is the same thing. So if you're going out for 3 hours, but you're doing it regularly, that volume of pressure can cause problems as well. So it's like adjust the saddle height, making sure that you've adjusted kind of how wide it is, and just playing around with it. Because you should really try not to have any of those symptoms.
As a side note, do you know of any brands that are creating chairs, seats, saddles?
I mean, there are
some,
because I'm not a cyclist. It's not, but there are some that are slightly wider and they have a bit of a dip, so that because obviously the perineum is curved like this, so it just gives it somewhere to sit without all that pressure on it.
If no one's doing that, get out there and do it, because the amount of cyclists
I'm sure there
and triathletes is massive.
Yeah, and I think people just play around with that. With either the angle of the seat as well, so you don't want an angle that's too high up. And then the other
What a valuable service that is. Find out how to do that right, guys. Fair dinkum.
Fair dinkum. And then
got the nuts.
But then also you get another condition called priapism, which is basically you just get an erection that won't go away because it's just overstimulating the pudendal nerve. And that's one of the other symptoms can be one of the symptoms of pudendal neuralgia. So you've got that set of symptoms that we know kind of what's causing that, but then there's also that set of sort of kind of testicular penile symptoms, chronic pelvic pain symptoms, which can mask itself as low back as well. And remember, some of the spinal nerves, some of the lower spinal, like L3, that feeds into that sort of area as well. So it can be mediated from your lower back. It doesn't necessarily have to be within the pelvis or the pelvic floor. It can be just a lower back issue. So you have to be able to distinguish distinguish when you're assessing a patient between these things. You're trying to provoke some of the symptoms either in the area or through movement patterns to see what's going on. So guys that are having painful sex, practically all of the sex positions for guys involve lumbar spinal flexion. So we know that if that's a trigger for them, we're going to have to find ways that they can have sex without that occurring.
And you said 5% of people respond in a positive way
to antibiotics. Well, they're the ones that
bacteria,
have, but that's how they have a bacterial.
To the antibiotics,
yeah.
Yep. And then there's the 95%.
It's caused not by bacteria.
Yeah, that cohort, that 95%, ideally would see a men's sexual loss physiotherapist. Yeah,
they would.
Yeah, because of all that.
Because we want to work out, like, if it's nerve, what are we going to do to help the nerves regenerate?
Yeah.
How are we going to take pressure off them? Or if it's muscular, how can we reduce the tone within the pelvic floor? And stress. You talk about one of the causes, sort of these high levels of stress and anxiety, which plague society, are part of that as well. So this non-relaxing pelvic floor that we see is often caused by stress, or at least exacerbated by stress. And you find a lot of people's symptoms, pelvic floor symptoms, go away when they're on holiday and things. And you're like, well, there's definitely a link there. And it's trying to convince people, how do they manage their stress without it sounding like you're a new age guru? Because we know that there are certain breathing mechanics that help reduce stress. We know that the prefrontal cortex of the brain responds to deep breathing. And that if we can couple that with pelvic floor activation and relaxation, that's hugely beneficial. So for the younger guys, I spend a lot more time teaching them where the pelvic floor is and how to relax it than how to strengthen it. What they don't need is excessive Kegels on top of being anxious. So you imagine that someone's getting performance anxiety because either they have premature ejaculation, which is also part of the pelvic floor issues as well. They're premature ejaculation or erectile dysfunction, and then they're going to do a whole bunch of Kegel exercises, and they just make the whole thing worse.
Even more premature ejaculation.
Yeah,
as you saying.
Yeah, because because what you want is that the certain parts of the pelvic floor have to relax.
Back to the
so you
Goldilocks.
don't. Yeah, because basically you know when you're about to ejaculate, your pelvic floor goes into overdrive, and it and then because you want to climax quite successfully. But if that's happening too soon and they're not relaxing, then all that happens is that they just they shoot too soon. And then the definition is if you either ejaculate within 1 minute of penetration or before you penetrate, that's considered sort of premature ejaculation.
Relax your pelvic floor.
Yeah. So what you do is when you talk about a guy having sex, there are certain at the times you have to teach them to actually be relaxing the pelvic floor. I mean, it's a bit of a mission for them to start with because they get too excited. But really, what you're trying to do is to help them sort of overcome that and have the pelvic floor just behave normally, so that they can have a good sexual intercourse.
So there's cascading benefits to breath work, isn't there?
It's very
phenomenal.
much.
As you were talking about anxiety, and then you were talking about sexual function, and then as you were talking about chronic stress and all the, I just went, wow, a proper diaphragmatic breath, let's say through the nose and out through the nose, which is going to help speak to the parasympathetic, the rest, digest, regenerate part of the nervous system, is such a powerful medium in so many areas of our life. And
it is.
Is it as effective? Where my mind just went just then, because as you were talking, you just took a breath as well. As you were talking just then, I became aware of my breath, and I did a full diaphragmatic breath, and then I went, hang on, my pelvic floor is sitting on this chair. Are they getting enough of an excursion while I'm sitting?
It's not huge by any means, and you've got, because you sit on your sit bones, so there's plenty of space sort of to go through it, and a little bit of stimulation of the pelvic floor is actually quite nice. It quite likes that. It's like any muscle activity. You know that you know if you sort of tap muscles, they contract. So it quite likes that proprioceptive input as well. But going back to your point about the nervous system in sex, the nervous system in sex, we often think of the nervous system as a continuum of this end we have the parasympathetic, which is all about digesting food and being relaxed, and at the other end you have the sympathetic, which is all about sort of get up and go and fighting
and freeze.
Yeah, exactly. But what you need to know is that the arousal part of sex is governed by the parasympathetic nervous system and not by the sympathetic nervous system. So you actually need a bit more relaxation to get aroused. It's like, if you're,
It's quite unique in human function.
It really is. So you almost have to think of them as rather than a continuum, as two separate things that are mostly like this, but often need to be like this, certainly for sex. Do you know yourself, like if people are trying for a baby and they're like, okay, we got to get going, got to get going, and the guy's not relaxed, his performance is much less he's much less able to perform because he's too uptight about it, and so he can't do that. So you need a certain amount of relaxation in sex and enjoyment. So you need the parasympathetic nervous system to be functioning well, and then the sympathetic functioning, which that's all about the orgasm end. And you've got these sort of different stages through sex where the different parts of the nervous system give over to the other one, and it's a really interesting interplay of hormones, but also how the nervous system sort of governs itself as well. Oh. So you can't, if you're really, really stressed, it's really hard to perform, as most men know.
Take a good breath during sex, when you're sitting at the desk, when you're exercising. My goodness, the breath is phenomenal. And can we sort of jump over to potentially the more serious side when we talk about the prostate cancer, which comes up, is a fearful thing that hangs over many men's shoulders.
I think it's the second biggest killer in men.
My God.
And it's definitely connected with age. I mean, can happen earlier. I have a young patient at the moment who's in his 40s who has had radical prostatectomy because of prostate.
Had his prostate removed?
Completely removed. Wow. And that tends to happen when you catch it early enough. And then the solutions are slightly different a bit later on if it's metastasized or anything like that, like the guy you were talking about.
They leave it in because what can they do? It's metastasized. It's probably in the bones now anyway, so we'll just leave it in there.
Exactly. So, but if you can catch it early enough, what the more likely to do is to actually do a radical prostatectomy with nerve sparing, where they try to not disrupt the nerves. But this tends to happen a bit later in life. And the problem is with prostate cancer is that there's no symptoms. The symptoms tend to be a bit urinary. So I can't go, or I'm going too much. But beyond that, there's no pain involved particularly. So often you miss it, which is why having screening for prostate cancer is really important.
What's the recommended age now for screening prostate?
So it depends. I mean, 50s. 50s. But there's no harm in sort of having a digital rectal exam or a PSA test early, although we're often worried with the PSAs that either you get false positives or false negatives, and that leads to unnecessary sort of interventions. So you want to couple it with a couple of other things. So maybe you do an ultrasound scan of the prostate along with a PSA test, along with a digital rectal exam, and you make a decision based on that cluster of reports that you get.
And the digital rectal exam, because the cancer often starts towards the rectum, when you do a digital exam, you're feeling the prostate. Does the cancer? What if it starts on the front side?
Well, you can actually get through quite a lot of it actually. So your doctor does. This isn't something physios do. So we don't do prostate exams. That's not our remit. Yeah. But you can go in and you can feel most of it as a sort of a walnut-sized lump, and they'll just kind of look around for kind of any enlargement or any sort of areas that just don't feel the same as the others or anything. But it's not necessarily comfortable to have done. Although some people find
neither
it
is
quite
cancer, though, is it?
No, it's true. But there are a lot of people that get a lot of pleasure through the prostate gland as well. But when you have it examined, your doctor will have a good sense of whether it feels normal or not. Yeah. And then you'll couple that with your PSA test and with either an ultrasound, or they can do an MRI now, or they can do a biopsy if they think there's something going on there. And that you just want to make sure you're not getting anything wrong. So the more information you have, the better. The problem is that, people can get too worried about it. So they'll have lots and lots of tests, and there'll be something that will come up, and they'll always focus on the problem test. They're like, well, there's something going on here, when there may actually not be.
Hey, let's focus on your patient who has just had surgery.
Yes.
Speaking to it's a lot of men out there that have unfortunately been through that process. Talk us through it, Simo, and what can we do? Because sexual function or lack of sexual function comes up when these sort of surgeries occur.
So he is a particularly He's like your poster child. He caught it early. He has already got back to sexual function.
What time frame?
So he 6 weeks. So
Go, son.
yeah, so he's really kind of ahead of the game, really. He's not getting spontaneous erections, but he is able to self-stimulate to achieve an erection. Although I don't think he's had. He was saying he hasn't had sex yet, but he's able to kind of masturbate freely, and so he's doing well. He has a little bit of dribbling, but no real incontinence. So he's actually come out of the surgery really well. But he is an anomaly most of the time after surgery. So what happens is the nerve bundles kind of sit under the prostate gland. When you take the prostate out, there's a whole bunch of weight that then goes and presses onto the nerves. And so you get a lot of disruption of the nerve signaling then.
Just on that, does it also press on the urethra, the hose from the bladder out the penis?
No, so the urethra is cut.
Or it comes around?
Yeah, so the urethra that is shortened.
Oh, okay, because they removed the prostate. So they can't spare the urethra. They have to go
so they have to cut
the hose,
it.
take the prostate, put it back together.
Yeah.
And then as a result of that, does your penis get pulled back in?
It does actually. You get this thing, and it only lasts about a year. But
that's why you're stretching your penis out.
You do penile, we call it penile rehabilitation.
Like the Tibetans do with that. Mr. Lifto, I don't know, Jim Rose's Freak Circus. Sidetrack. No. Seriously, Jim Rose's Freak Circus.
We don't do that.
Freak Circus came to Australia. This is total tangent, but seriously worthwhile because it could be a new treatment strategy for you, Colin Symmonds, at Joint Dynamics. But I'll let you be the decider of that. Jim Rose Freak Circus, right, came to Australia. These guys where dudes stick nails up their nose, and there was one of the primary quote unquote performers was this guy, Mr. Lifto. Mr. Lifto had many piercings, and he would, for example, lift heavy things off his nipple rings. Here's where the story goes. Mr. Lifto also had some piercings, not his cock and nuts, his penis, and Mr. Lifto would lift heavy things with his penis. And then one day I saw there was this Tibetan practice with the monks towing something with their penis. Probably not the ideal, but is it an end goal? Mr. Lifto.
You know, everyone needs a goal
each
in
their
life,
own,
really.
Each their own. Sorry, a little sidetrack on the Joint Dynamics podcast, ladies and gentlemen, but worthwhile mentioning. So that's why the educational part of this podcast is when you have the prostate removed as a result of the cancer, hasn't got metastatic, hasn't got out into the bones, thankfully. Got it early, quote unquote, removed it, cut the urethra, removed the prostate, put the urethra, the hose from the bladder to the penis where your wee and semen comes out, back together, pulls your penis back in, take me from there. So, now I see my men's health physio.
Yeah, so the penis will retract slightly. So everyone gets this feeling that it's
willy.
But it's not. It's actually not small. It just looks smaller.
Yeah, that's what I mean. But that plays with the men's psychology.
So what you do is then you teach stretching techniques and you teach a way of kind of rehabilitating the penis.
Not like Mr. Lifto. Not like that far, people.
And there are no nails involved.
Far out.
And no towing anything, really.
Let the Tibetans and Mr. Lifto do that.
Although actually part of the pelvic floor rehab, you can use an erect penis to create actually more load on the pelvic floor.
Hang a wet towel over it like we used to when we were teenagers.
You could try that as well.
There you go.
Actually, you
so
do.
I've heard. So I've heard.
You don't need that, Andrew.
No. Back to.
Oh yeah. So a couple of things happen. So you've got a shorter urethra. So the pressure from the urine in the bladder is higher. So you end up with incontinence because there's a small sphincter called the external urethral sphincter that then becomes overpowered, and that's the front part of your pelvic floor, and it becomes overpowered, which is why you leak and you have incontinence to start with, because that sphincter is just not strong enough or capable enough to withstand the increased pressure from the urine. So ideally what you would do is, going into prostate surgery, you would be as fit as you possibly could. That seems to make a difference.
Any surgery, we know, huh?
Yeah, and you'd be lower weight because you don't want any more pressure on the bladder and on the pelvic floor and the nerves. And then you would see a pelvic floor rehab specialist beforehand to teach you how to activate this sphincter muscle, because you have volitional control over it. So you would teach how to activate it, and then you try and get that sort of stronger before you go in and a bit more competent, so that it significantly reduces the amount of time you're incontinent for. So the guy I was talking about, he, 6 weeks afterwards, he's got a little bit of dribbling, but that's about it. And they probably got a little bit of bladder issue going on separate to his surgery, but really he's doing very well. Whereas you can get up to 2 years of incontinence and you're wearing pads, which is why the rehab is really important. You want a good, strong anterior pelvic floor to withstand the pressures, those increased pressures because of your shortened urethra. So we teach that as well. The other thing you need to do is you have to be able to get an erection, because what tends to happen is, so when you sleep at night, you have 7 or 8 erections throughout the night, and you often wake up with an erection. It's the body's way of dealing with the plumbing. So it wants to make sure that it flushes things out, that everything's activated all the time. But after prostate surgery, it happens less here, but in England, you get given a vacuum pump, because you have to artificially keep erections going until the nerves have started coming back sort of into play. You can have spontaneous erections. So the
role of the penis pump is to place your penis in the vacuum, and that will suck the blood in.
So it sucks the blood in. The problem is it only works on the superficial veins. It doesn't work on the deeper ones, which is where you really need it. But it's better than nothing. And you'll be put on low doses of Cialis as well, so that the nitrous oxide. So you're much
like a low or a slow release Viagra.
Slow release Viagra. So and you want that one because you want to be able to stimulate it all the time where possible. So you'll do the vacuum pump. You'll be doing penile rehabilitation. Hopefully your incontinence will be very minimal after that. And then we do things like we do diaries and we check the weight of pads, and we can tell how much you're kind of urinating and drinking and things like that. So we can tell when you're getting better. But going in with a strong pelvic floor is the optimum thing to do. And then we know that for sexual function, we really have to wait for you to start being able to have a useful erection. So often...
You said useful erection. Is there a non-useful erection?
Yes, you can get sort of semi-erections where you can't penetrate particularly, where everything's sort of coming back online, if you like, which is again better than nothing. But you want kind of a full blood flow into the penis, and you want to be able to keep the blood flow in there so that you can use it. So the guy that I'm choosing at the moment, he doesn't have any spontaneous erections, but he can self-stimulate to get an erection. So that the stimulation of the erection actually occurs higher up in the spinal level. So I think T12, I think that level up in that very low part of your upper back, that mediates that, which is why kind of sometimes paraplegics, you can find a low paraplegic can get an erection, where you can stimulate it, but he can't get it to go with his brain.
Just on another side note, I remember when I used to play rugby league, a sport, unfortunately sometimes injuries occur in every sport, but I'll never forget one time I was playing a game and someone got a spinal injury, or a suspected spinal injury. And someone said, with some spinal injuries, there's an instantaneous erection. So people look for an erection. Have you ever heard that?
No.
My mind just jumped back to that
moment. No, not that I know.
Because when you said T12, my mind went, well, that's where the psoas, the majority of the psoas. I wonder, is there a relationship with the psoas into that, or it's
not that I know of, really. But we know that the lower level, the high level spinal cord injuries, you can often still get an erection with that, but that's sort of a stimulated erection. So this guy can stimulate erection. He doesn't have any. It doesn't spontaneously erect at the moment, but that will come back. But he
with quote unquote exercise with stimulation.
Yeah.
So he's got the penis pump to help engorge the blood.
But he may not need that now because he can get an erection, and I think he's masturbating frequently so that he doesn't necessarily need to, because he's going to get those deeper veins full of blood, which is kind of what you want as well, because you just want the health of the penis to be maintained, because without an erection the penis atrophies.
Use it or lose it applies there as well.
100%. Yeah. So you want the idea is like, we've got to keep this going until the nerves come back online, and then everything can become normal again.
And is there a timeline, just say on that example we're talking about where the prostate has been removed, is there a timeline for the nerves? Like just say how you were saying how the
up to 2 years.
Up to 2 years.
Yeah. So you can you just, and also what they often forget to tell you is that you will never ejaculate again. You can orgasm.
What? Oh yeah, because the seminal vesicles are gone as well.
Yeah, everything's gone. So
you'll get, I never knew that.
Yeah, you'll get the sensation of orgasming, but you won't ejaculate again.
No fluid will.
No.
Sorry to not being insensitive, but that's what's going on.
Yeah.
Oh, wow.
So all the sensations there, just none of the mess.
Nothing. Okay, there's a benefit.
Yeah.
There's a benefit there.
Yeah.
Well, I just wanted to jump over, like a relative makes sense, jump over here, not a Mr. Lifter. But when you did those courses, let's say recently the Four Horsemen and the other one, because we already touched on it, you said, the size of the penis, it's retracted. So we're talking about the psychology of a man at the moment. And then reduce sexual function, potentially weeing myself. In those courses, how much do you touch on psychology? Because when men come to you and we don't talk, we don't do a good job of sharing our problems. Mm-hmm. But I'm sure in a professional setting, sooner or later they're going to say to you, Simo, mate, I just feel pretty shit about myself. You know, sometimes a man in this modern world is portrayed as a vehicle to carry around an erection, you know, that when we talk about masculinity, you know, I am because I get stiffies, so to speak. Is that what that guy said? Yeah, because I get
Are you
stiffies.
Quoting Shakespeare again?
No, I'm not quoting Shakespeare. I'm quoting that French guy. I think, therefore I am. But back to how much of those courses and your study into men's health and sexual dysfunction is on psychology. Like, can you speak to that to which you're confident?
Yes, no. So the physios all, in theory, we should have all had training in basic counselling skills, because when you're dealing with chronic pain, with patients with sort of conditions like spinal cord injuries, amputations, you spend more time with them than probably any other part of the healthcare discipline, apart from occupational therapists. So occupational therapists and physios spend a lot of time with people. So we all have basic counselling training. However, when you get to this level, you are often ill-equipped to know what to say to guys. So it's always important to have a mental health care practitioner that you like to work with, either a psychologist or a counsellor, that can help guys navigate these changes, because they are significant, because lots of our ego and our self-identity is wrapped up in our sexual identity. And certainly, you know, no man wants to be weeing himself all the time. Although, you know, I've got one patient, he's really interesting, an Aussie bloke, and he's been incontinent for a long time, but he knows what his triggers are, and he tells all his mates. And he's really open about it. Yeah. And they all have sort of embraced it, because he doesn't feel embarrassed about it now. It's just something that he has to put up with. So he knows that if he has a couple of beers, he needs to know before he gets home, where he's going to stop. And then he knows that certain things like whiskies trigger his bladder as well. So he's got an overactive bladder. Yeah. So he has to be wary of that. But he's told all his mates, everyone knows, and they all rib him about it. But it's normalised, which is what you're looking for.
That in itself is therapeutic.
It really is. And that's why we have to normalise these discussions on sexual function, on fecal and urinary incontinence, on all of these things, because if we don't, everything stays in the dark again. And what surprised me in Hong Kong is that I do a lot of talks to corporate wellness groups within companies, and I am technically cock-blocked a lot of the time, because there are certain things I'm not allowed to say. I'm not allowed to say erectile dysfunction, even though it's a medical term, because people might find it offensive.
That's fascinating.
So it's this idea that
frustrating.
And it is, because you're kind of like, well, we need to tell guys what can go wrong with them and where they need to seek help. But we can't talk about any of the terms. In fact, one talk I had to bin because they took so much out of it that it was pointless having the talk. I said, you should probably just have a health talk, even though November is Men's Health Month. And this was a legal firm, so it wasn't like a group of kids. And I said, well, why don't you just tell people that we're going to be discussing sensitive topics? And I understand that in conservative societies, people are sensitive about these things. But that's not an excuse not to arm people with the proper information. And as a physio, I feel it is irresponsible for me not to give as much information as possible, but in the most palatable way that we can deliver it. I mean, I'm not going to go into talk about cock and nuts, because they won't want that.
It's a podcast, ladies and gentlemen.
So they need to warn people, and we need to be able to have these frank discussions. Because, so for example, you touched earlier about the kind of morning erections. So morning erections are now heavily linked with heart disease, because we know that I think the blood vessels in the penis are about a third of the size of the ones in the heart. So if your penile blood vessels are furring up and they're getting sort of narrowed, you will not be able to achieve an erection in the morning. You'll find it's not as hard as it once was. That's happening within your heart as well, where the blood vessels are larger, but not so large. So it's often seen as a precursor, as a warning for heart disease. And this firm told me I couldn't use that and tell guys. So I said, so you're telling me I can't give men an early warning sign for the biggest killer in men because it might offend someone in the audience? I said, do you not see how ridiculous that sounds?
Death is quite offensive as well, isn't it?
It really is. So, so it's allowing people to have this information in a kind of an open forum where they don't feel that we're stigmatizing any of this, and we have to remove these taboos as much as we possibly can.
How good's this podcast?
Very good.
Far out. Let's get the word out there. A little jump over again. Which sort of answered the question of the soundbite at the start of this podcast was, if you're waking up without a morning erection, one of the things, it may be indicative of heart disease.
Yeah.
As a treatment strategy, what if I woke up and Wonder Woman I had like this big poster on my ceiling. I woke up and there's Wonder Woman. Boom. Is the result part of the treatment? Could that ever work?
No, because they're still furred up. So
or Superman, whichever you want. Yeah. But you know what I mean?
So you'd still have to sort of see, you need to check whether your heart's having a problem. The thing is, all the things that cause problems in your heart cause problems in your penis, things like poor diet, nutrition, sort of being overweight, all of those things. Because we're just talking about structures. Because these structures are involved in sexual function, we often think that they're different and magical, but they're not. They're just kind of a bunch of muscles and soft tissues and blood vessels and nerves that have to work in a particular way to function properly. So if you are overweight, if you are eating crappy food, if you're drinking too much, and if you're smoking, which is probably the worst thing you can do for your erection, will fur up your blood vessels. By fur up, Simo, you mean reduce the capacity for blood to pass through. You get sort of build-up of plaque in the same way as your coronary vessels do.
Yeah.
It's exactly the same mechanism. So if you find your morning erections aren't happening as frequently, or they're not as strong as they once were, although with stimulation you can get going again, then you will need to go and see your doctor. But then lifestyle modification is the most important intervention that you can have. So it's making sure that you're eating healthy, that you're at a good weight, and you stop smoking and reduce your alcohol.
One of the most powerful anti-smoking advertisements. Do you remember the Marlboro man? This guy who's the man's man sitting on his horse, and he had a cigarette and it was flaccid. Do you remember that? It was one of the most powerful stop smoking, because you won't get a stiffy. Your morning erection will stop. Well, your erection will suffer as a result of reduced cardiovascular health.
I think, but part of the problem with all of this information is, if you are currently having good erections, you ignore it. So all of the calls to give up smoking based on something that may happen to you in the future just don't seem to work as well. Because they're like, oh, well, I'll just sort it out when it happens. Yeah. But when it tends to happen to people, you're in a high-pressure job, you're in having relationship issues, money issues, then you find you're having an erection, and it gets lost in this milieu of things that are just going wrong for you. And it's hard to sort of pull it apart, because we very rarely get one thing happening that causes one thing. It's a whole bunch of things, and they all get kind of lost together.
And you find, let's use Hong Kong as an example, and the client base that we work with frequently, they'll say, I just don't have time. Until it gets really bad, I'll ignore the symptoms, or I'll ignore the discomfort, I'll ignore my sexual dysfunction, or I'll ignore my incontinence just because I don't have time. And then when it gets bad enough that you can't ignore it, that's when I'll do something about it.
It tends to be that, but that's the world over, I think.
Don't be that person.
I don't think it's just a Hong Kong thing. Yeah. Although, I've got one young patient at the moment, he's in his 20s, who came to see me because he contacted me by phone first because he believed he had this condition called hard flaccid syndrome, which we don't fully understand, but the result is you get a permanent erection which is not hard enough to penetrate. It doesn't go up and doesn't go down. And often it's one of the causes are people who are very enthusiastic self-pleasurers. So they kind of, you yank your dick off, you destroy a bunch of blood vessels, or you damage them, and you damage the soft tissues. So I'm not talking about Peyronie's disease where you break your penis, but...
What is that one's called?
Peyronie's disease.
You break your penis?
Yeah,
How do you know bones in there? What do you mean you break your penis?
You snap the soft tissues and you cause a plaque to occur.
Does that heal?
It can do. It depends if it's more than 30 degrees or not. If it's less than 30 degrees, you can use penile pumps, you can use shockwave therapy, you can use penile rehabilitation to kind of correct it. Because what you're trying to do is as it bends, you get plaque formation and you're trying to straighten it out effectively.
One mechanism that might happen would be over-enthusiastic sex. How would you break your penis?
Well, if you're having sex with your girlfriend and she's doing sort of cowgirl, and she's bouncing up and down, and then she kind of jumps off, and it's And penile fracture is a thing.
Wow.
Yeah, even though there are no bones in there.
Okay.
And then, so this guy had contacted me because he felt that he had got this, and it turned out that he had enjoyed a lot of masturbation, and that he'd damaged himself, and that he'd gone to a urologist who said, "Oh no, everything's fine. You'll be absolutely fine." But he still contacted me, and eventually came in to see me because he felt there were changes in his penis. A huge proportion of that was psychological as well, because he talked himself up into having sort of some notional problems about his penis that he just then. And he said, "Oh, I'm not going to masturbate ever again." And so the conversation was like, "Well, actually, you have to normalize everything. So you need to go back to it. You need to not be frightened of it. Or when it comes to you having sex later in life, you're going to be absolutely paranoid. And that itself then becomes a prophecy that kind of fulfills itself." So that mental health component, coupled with a very conservative society where you don't have people to talk to, and a group of people, guys, who just don't talk to people anyway, and you're left with a whole bunch of problems that are easy to sort out. So you can sort the physical things out for the most part, and then you need to sort out the emotional and the psychological components as well. But if you leave them for too long, it just becomes much and much worse.
And then I guess if we layer in talking on the psychology and the suffering in silence, part of the treatment for prostate cancer can be ADT, androgen deprivation therapy. And then, not to be insensitive, I mentioned this with Tim as well, basically chemical castration.
Yeah.
So medication, let's say, that reduces, if not obliterates, testosterone. And then we know via research that you increase the likelihood of suicidal ideation by 400 or 4,000%. It was crazy. So just like, one of the things that surprised me that I'd never heard is if you have your prostate removed, when you ejaculate, no fluid will come out. Like that should be told. I don't know if it is or not.
I think most doctors are pretty good about it now. I mean, I have had a couple of patients that weren't told that was happening, and that freaked them out. And
then, because one of the things that Tim touched on from episode 116 on, it's called Patting the Shark. He wrote a great book about it. But he spoke about the experience of being told he had stage 4 metastatic prostate cancer, and he just, he ended up having, he did mushrooms to help him deal with the post-traumatic stress of that day. Yeah. As a result of that, he felt love towards the doctor, because that poor doctor has to do that every day. So can you imagine the position that he's in? But when he went through that process, he felt that he wasn't well educated and equipped enough, and he felt that there wasn't a human connection enough that allowed him to deal with life-transforming news of, guess what, you've got prostate cancer. And so I imagine, hopefully, that if someone is prescribed, one of the things that can help you, it's almost like weighing up. It's bad for you, but it's not as bad as dying of cancer. So we're going to give you androgen deprivation therapy, ADT. As a result of that, your sexual dysfunction is going to go up. You're not going to be interested in sex. Your mood, your motivation is going to go way down as well. Couple that with the the contents of the guts falling onto the nerves. Have you ever worked with anyone that's gone through, they've had the surgery, they've had ADT? Is there a timeline that they're given that you could share on?
If you have complete removal of the nervous system around there, you're never having an erection again.
Yeah, but now you're saying they do nerve sparing surgery.
So nerve sparing, but that tends to be early stage prostate cancer.
Yeah.
The later stage ones tend to be things like the androgen deprivation therapy.
Okay.
And so they tend not to be done together necessarily.
Sometimes they just remove a small part. They're called boring.
Yeah,
My
so
father
you can take small portions out.
Yeah.
You can use kind of radiation therapy, targeted things like that. But with the testosterone stuff, what's interesting is that everyone, and quite rightly so, thinks about testosterone from a sort of sexual performance and wanting to kind of get aroused and things like that, which it absolutely is. But as you touched on, it's much more to do with kind of your emotional stability, your mood, your confidence, your planning, your drive, all of that.
The hormone of focus.
Exactly. And so the testosterone peaks at about 18 years old. So that's when you're your highest, and it drops off at about 1 to 2% every year, sometimes for 3%. And we reckon that 40% of men in their 40s have lower testosterone than they should have. And so we don't think about that going into decline quite so early, but it does. And often the symptoms that they get aren't sexually related. They're more to do with mood and depression and with you not being able to sort of execute at work, and you become less focused. And I know this because this is what happened to me. It was one of the reasons why I think I've sort of moved into male pelvic health, was because I remember I was living in South Africa and I just felt my testosterone was low. And because I lifted lots of weights, I was very muscly, and my doctor refused to test me because she said, there's no way, your testosterone was low. So then I moved from there to New York to complete my master's. And I remember getting my first pack of research papers for my master's, and I bawled my eyes out. I felt so overwhelmed and I had no idea what was going on. And I thought, I'm clearly depressed. I don't know what to do about this. So I went to see a doctor. And eventually I was referred to an endocrinologist who sampled my testosterone levels. And her exact words were, "It is a wasteland." She said, "You have had no testosterone, very low testosterone for years." I had a DEXA scan, so I was osteoporotic in both hips and my lower back. And I started having injections of testosterone weekly. And within 2 weeks, I was 1,000% better. I just felt entirely different. So often these symptoms can mask as other things. So you can feel depressed when really the issues are testosterone. So it's always worth, so as you enter your 40s, having that checked regularly.
Are you still taking testosterone?
Yeah.
So is it still every 2 weeks or is
No. So I do. There's creams and gels you can get. Yeah. So I have I use topical. I went through a period of having them every 3 months, where you can get a thing called Nebido, and you get this injection, which just means that halfway through that 3 months, you're absolutely raging for sex all the time. But then it all sort of tails off towards the end of the 3 months, and they couldn't quite get it right. And my doctors here took me off that and said, I think that's actually not helping you. So they put me on a cream, which is a much more stable topical way of doing it. And so what they found was I have a thing called a microadenoma that sits under my pituitary gland, and it's probably interfering with some of the cascade of making testosterone. So no amount of the solution we give people would have made a difference. And there are things you can do to naturally boost your testosterone as well, which we try and sort of get guys to do, like lifting heavy weights.
Yeah, there's even a specific testosterone protocol now, whether or not it's marketing, but there's principles.
There's some good research. I mean, training in the afternoon seems to be better than training in the morning. People who are chronic cardio adherence, they suffer low testosterone as well. But if you're going to lift weights, do high intensity work, all the stuff that we do power basically seems to be really effective.
Yeah, it seems the principles are
I'm gonna try
metabolic overload and mechanical
Yeah.
overload. Yeah, it's really nice. It's a great drink. What's it called again?
Ooh.
Honey Digest. It's bloody
It's
good.
fizzy like beer.
Yeah. Hey, we
that's
answered one
yummy.
of the questions from the start, but there was another one that I think you sort of touched on. Men, we go out, we have a couple of beers, a couple of drinks, and then we come home. And many men, look, I'm 51, many of my mates will say, I'll get up and have two. I had a terrible sleep because I had to get up and go to the toilet.
No, actually, what we were talking about before the podcast was guys who wet the bed.
Oh, jeez.
Yes, so guys will go out and get tanked up, and then they'll come home and their girlfriends or their wives or their boyfriends get really upset because they wet themselves, and it happens quite frequently. But it's to do with the fact that we have what's called an antidiuretic hormone in our bodies. So when you go to sleep at night, you release this, and it stops you weeing all the time, or else you'd be going quite a lot anyway. And so what they found was that the alcohol shuts that down. So there's a real reason why guys who drink a lot have problems with that. But if you have that as well as either a pelvic floor issue or a prostate issue, you are going to be going up quite a lot and weeing a lot.
Got it. And then the Four Horsemen. So that course, something that you said that I thought was very interesting.
Yeah, it was
from a male sexual perspective.
it was a brilliant course, and they touched more on sexual function than I thought they were going to, because it was going to be because it was about pelvic pain. Really, so we're looking at why do guys get pelvic pain, and pelvic pain is considered anything that generally occurs if you're wearing Y fronts. Anywhere within that kind of Y front region would be considered pelvic pain. But the course was really about how do you identify where that's coming from. So is it a spinal issue? So is it kind of your lumbar spine is having a problem, and that every time you go into flexion it pisses the nerves off and you're getting these strange symptoms? Or is it a pelvic floor issue itself, in which case you need to address it from a pelvic floor perspective, and you have to examine, how the pelvic floor is working and can people control their pelvic floor. And so you'll do that with either sort of some ultrasounds. You can have a look around and you can see, if you go up sort of in the perineum, you can see how the pelvic floor contracts. And it's got a nice bit of biofeedback actually, because you can teach someone, you can gamify it for a man. It's like, well, can you lift this up here? Yeah. And then, biofeedback is quite valuable. So we can do that. But then, or is it a nerve issue? And then how do you identify whether it's coming from various nerves? You can poke around different nerve areas in the body and see if you can reproduce some of the symptoms, which is what ideally what you're trying to do. Once you can reproduce the symptom, you can say, oh, actually, this is possibly where it's coming from. And then your treatment is focused on where you think the issues are.
From a generalised perspective, what do you think we can do better, A, in your industry, and then B, for you out there that's not seeing a physio or, not seeing a medical practitioner that is just maybe suffering in silence? What do you think we can do better?
I think education is the most important thing we can do for anyone and in any
sphere. You would give 3
really.
points on education. What would it
So things like checking yourself, checking your testicles, trying to work out if you're having some form of symptom, going to see someone. So it's like, if I am having problems urinating, or if I'm taking 20 seconds to get going when I'm at the urinal, or if I'm not completely emptying, you probably should talk to someone about that. And physios are well placed to have those conversations with. And generally we work well with urologists, so we'll send you off to your urologist and have them do studies to make sure that there's nothing more sinister going on. And then we retrain the pelvic floor so that you can...
I love you said that, retrain. That makes it accessible to me, doesn't it?
It is. And it's set of muscles. And we have to think of them in the same way. They just happen to be attached to parts of our anatomy that we are a bit conservative about. And so, sometimes when you're examining someone and you want them to activate the pelvic floor, one of the things to do is like stand them in a corner and say, can you flick your penis up and down? And if they can do that, that front part of the pelvic floor is working quite well, and that you can use that. Because often the cues we've given men to contract the pelvic floors don't work, because we've taken the cues from female pelvic floor activation and we've tried to translate it for men, and men don't want to blossom like a flower, really. It doesn't mean anything to us.
Lift the tissue up away from...
and they're like, but when we say nuts to guts, you try to lift your nuts up.
Just did it.
Every guy listening to this now is doing that.
Yeah.
And he says, I'd like, can you can you stop yourself peeing? Not that we sort of think that's a sort of things like so that's that anterior part of your pelvic floor, that external urethral sphincter. That's that. Can you stop yourself? Can you lift your nuts up? And then can you stop yourself pooing?
That's all 3 layers.
That's all 3 layers.
Say those 3 in the way that you would cue a client. No, a man. Oh, in the way that you would cue a man. Can you just give that one more time? Because we can all do this, but just not too much because we don't want to get tight.
No. So basically, what you're going to try and do is, can you stop yourself peeing? Imagine you're doing that. Can you do it 5 times hard and fast?
Hard and fast. Boom. I shouldn't make that noise,
actually,
should I?
Really,
shouldn't make that noise.
It doesn't make that noise. It goes that's the noise it makes. So you're trying to build up some power, which is kind of what you need for that.
This.
And then endurance as well. Can you do it and hold it for 5 to 10 seconds?
But do I bring on slow or bring on fast?
Slower. Do you want a slow mid contraction for that?
Yeah.
Remember,
I even feel that towards the top of the base of my penis.
Yeah, you do, and because that's the muscle that's working.
Oh, go on, get me in the corner.
So the thing is, so then can you do that?
Not to make jest.
And then can you this nuts to guts thing?
That's my next one.
Is hard. It's like imagine sometimes it's like that you're being lowered over boiling water and your nuts are about to hit
freezing water. Freezing water is better.
And then can you pull it up?
Ooh. Yep.
And like that.
Hang on, so I've stopped the wee one. I'm separating, segmenting.
So in all honesty, they all function together, and it's very hard to isolate them out. But we know from research that you can make it the contraction more at a particular point of the pelvic floor activation by focusing on this specifically.
Okay, so we're on step 2. Step 2, I'm lifting my nuts to my guts. Hang on, how many reps? Give me a.
So do 5 fast reps.
So like,
hard as you can.
Boom. What noise would you accompany this one with?
Ba-doing.
Oh, mate, I'm doing a great job here. 5, and then
you're going to do some endurance ones. You want 50% contraction.
Yep,
hold for 5 to 10 seconds. And then relax.
And breathe as well. Don't hold your breath, guys out there. Let them go.
So you breathe. So as you relax them, that's when you breathe in.
That actually felt nice for my perineum. Like when I relaxed, I felt my perineum, like the deeper pelvic. I think I felt the pelvic floor.
And then the third one contraction is
hit me, Simo.
Stop yourself pooing. Or stop yourself farting.
Okay.
Because that's the puborectalis muscle.
No, I'm joking. That's an honest joke.
So the puborectalis muscle hooks around the rectum.
Yep.
And as it contracts, it basically creates a bigger angle to stop you, kind of to keep the feces inside.
With that one, just say I think I was a little bit over enthusiastic on the first one. I felt my pelvis roll back. Was I trying too hard?
Yeah, you are.
There should be no movement. Just stay neutral.
So you want
breathe as well, Andrew.
And you want no other activation. So your glutes shouldn't activate, your obliques shouldn't activate.
Yep, and just for fun, a rep scheme that's generalised is 5 reps.
Yeah.
Smashing it, as in lifting heavy, and then 5 slow.
To be honest, men are very good at this one.
Aren't we? We are.
We're very good at the back one. We're not very good at the front one. And it's trying to help people to actually not do that too much, because often they're like, oh, I can do this. It's really easy. Yeah. Whereas the front just needs a bit more work. And then the idea is to try and get them all to go together.
So I go, hang on. I heard you once say, pull the turtle head back.
So that's the front one. So that's the stop yourself peeing.
Yeah. So
the other version of that is think of it as a turtle head and try and pull the turtle head back in.
Got it. Protective mechanism.
Yeah. So, but all of these cues were developed for an American audience. Oh. So, and these were the ones that have been shown to work really well for activating the pelvic floor, but it doesn't necessarily translate around the world. So stopping yourself peeing seems to be better in Asia.
Oh, really?
People seem to get that better than turtle heads.
Nuts to guts, that's got to work well in Australia. Comrades? Don't you reckon?
Yes, I do. So don't hang anything off them.
Got it. Mr. Lifto. So, and then ultimately, just say to conclude the physical part of this podcast.
Oh, so, hold on, you're going to do them together,
3.
though. Yes, you do all 3. So the idea is, like, can you contract front to back?
And then do I go back to front?
Yeah, you can do.
Oh, go on. It's like a wave.
So can you do, because they do activate. Often it activates back from the back to the front because we're better at that. And so then you do, but then you need to contract them. Like, can you do the powerful ones and then relax, and the powerful one then relax, and then can you do the smaller ones, 50%?
This is fun. And should I be standing up, or it doesn't matter?
Yeah,
just do it when you can.
100% does matter. So we teach it lying down.
100% doesn't matter.
Does matter.
Oh, it does.
It does, because we teach it lying down, because then you don't have any extra pressure from the internal organs.
Gravity.
Yeah. So the first thing you want to do, as soon as we've got you doing it, we'll stand you up. Yeah. So we'll lean you against a wall, and you'll do them there. We'll have you off the wall. We'll have you do it in stride stance, because as you take a stride stance, you get this torsion of the pelvic floor. So you've got more load to control. And then we do it in a squat. We do it all sorts of positions, because you want it to be able to activate in real life, not just lying down. But you teach it in lying down. It means you can use the ultrasound probe easier to see when people are activating.
And on movement for a second, when we look at the quote unquote the origin and insertion of these muscles around the pelvis, when my pelvis moves, let's say sagittal frontal transverse plane in our industry moves forwards and backwards, side to side, and then it rotates out and rotates in, that's moving those muscles.
Yeah.
So movement in itself, with diversity, forwards and backwards, side to side,
100%.
rotate in, rotate out, is a great way to keep those pelvic floor muscles healthy.
Yeah, and there's the internal obturator internus muscle, which is a kind of external rotator, that is one of the only muscles that actually attaches onto the pelvic floor itself, because it has a sort of a fascial link in there. So lots of hip rotation stuff is really good for the pelvic floor as well. So when we're trying to relax the pelvic floor, so that's your activation. You're relaxing. We do a lot of yoga sequencing. So things like happy baby pose, child's pose, all of that. And we use breathing to try and relax the pelvic floor. So we do that in lots of different positions as well. So it's not just about lying down, because most of the time when things go wrong, you're not lying down, you're doing something.
Yeah.
So you have to be able to have the pelvic floor.
Makes more functional sense to do it standing up as well.
You treat
Start laying down.
any other muscles.
Yeah.
You treat it in a way that someone learns how to control it, and then once they've got the neuromuscular control over it, you have to challenge it. So you're going to challenge it with, again, intensity. So you're going to be doing like powerful contractions. You're going to try and do it for endurance. So you're going to have those mid-range contractions for longer periods of time. But then you try and put some load onto it. So sometimes, again, we talked about sort of we'll have them doing these exercises lying down. But, often we'll say to a guy, when you get an erection, we use that as a bit of extra load onto that front of that superficial part of the pelvic floor, because it's just you got blood in there, so it's a weighted exercise. So it's the same thing. So can you stop yourself peeing while you've got an erection? Because
you do them all while you've got an erection as well. Cripes. And often when the women's health, so we've got a women's health centre at Joint Dynamics called Evolve, and you often...
I am part of the women's health centre, technically.
High five to you, Simo. High five to you. So often you'll see the women when they come into the gym, they'll be sitting on actually, what they'll do, they'll put the stability ball against the wall, and then essentially they'll back their bum, their pelvic floor, onto the stability ball, and the pressure of the stability ball onto the pelvic floor is a way to bring proprioceptive awareness, but also stimulate. And men should do the same.
We do exactly the same.
Yeah. So even sitting on a ball and bouncing on it is good for the pelvic floor.
But isn't it funny that we can do that with a woman in the gym and no one will bat an eyelid?
Yeah.
I have to do that in private. A guy doesn't want to do that in a gym.
A dude doesn't want to back onto a ball.
No, definitely not.
We're a weird animal, aren't we? If you were to, with all your experience, what do you think most men should know? I don't know if we've touched on it enough, but if you think about, because I think that was incredible that organisation in Hong Kong, a professional organisation, you were talking about science, medical science, yet you were essentially muffled.
I think men need to know that you shouldn't have problems peeing, you shouldn't have problems pooing, and you should have a good sex life. And that one piece of research that came out a couple of years ago, and I haven't actually looked at it properly, but it basically said that the prostate, you need to ejaculate something like 21 times a month.
21 times a month?
For a healthy prostate gland, because it likes to ejaculate, likes to clear things out as well. It doesn't like stagnation.
So my Wonder Woman, even though you ignored it when I said it,
it
still makes a bit of sense, doesn't it? Wake up and there she is.
I mean, but if it's Henry Cavill as Superman, then
there you go. He's a good sword too, isn't he? Hello.
So things like, I suppose a rule of thumb is, if you're having symptoms that make you feel embarrassed, you should talk to someone about them. Whatever they are, whether they're urinary, fecal, because fecal incontinence is a real thing for guys as well. When that puborectalis muscle is not working, or there's some nerve stuff going on, you're going to get some kind of anal leakage as well. And so guys need to know that it's not just women that have kind of urinary and fecal incontinence, that they can have it too.
And then would you add to that you know what, with talking about it and with seeking help and with quote unquote training or an intervention, most of us can get better.
Yeah.
The vast majority of those symptoms will abate, and you will. So that's sort of something that I'd really like to know.
So we talk a lot about sexual function because everyone's interested in that. We talk about incontinence because people are like, well, I don't know with myself. But the fecal incontinence stuff is also connected with constipation as well. So a large, huge amounts of men will have constipation issues, which are kind of problems with stress as well, irritable bowel syndrome, but also things like not drinking enough water during the day.
I was about to say that dehydration comes up a lot.
Dehydration or over drinking water as well, where they just drink too much. But you need to be sort of drinking throughout the day, small sips, but you need that fluid within your colon to help you kind of evacuate the stools. But often that gets impacted. And then if you add stress to that, and people, if you think about the people who are in finance in Hong Kong not wanting to get off the trading desk to go to the toilet, so you get into habit of just holding on to your stool for too long, and then you spend a lot of time straining and pushing to get it out, and then you overstretch the sphincters. So the internal anal sphincter can get overstretched as well, and that's not attached to, that's a part of an independent nervous system, the enteric nervous system. So we don't have any control over that as well. So that it's very, I don't know how it just makes, I'm so interested in this. So it's like your internal anal sphincter can sense the difference between gas and fluid and solids.
Bloody genius, isn't it?
It really is.
Seriously, what it can do, and it can release gas while not letting the fluid out. That's phenomenal.
Exactly. Except when it goes to run, you've got about 30 seconds when you desperately need to go, and if you've got diarrhea as well, you do have about 30 seconds before it will all go wrong. There's only a certain point you can control it for, and then it will all happen. But it's such a strong sensory organ as well. So you've got an external anal sphincter as well, which we do have control over. And that's the one you kind of squeeze together to, if you feel you're going to...
As you're making your way to the toilet.
Exactly, running to the toilet.
Quick story, sorry. One of my mates, great bloke, when we travelled through, it was Europe together. And unfortunately, prior to Europe, not unfortunately, it was great, we went through the Middle East together as well. And travelling through the Middle East to eat some foods that may indeed have a negative effect and may have a lasting negative effect. We all got some type of gastro. And my poor mate... I was filming him on video. He's one of my best mates, and so it was just brilliant. I knew that we all were having problems as far as diarrhea. And we were in Munich, about to go to the beer fest, and we were just having a look around the day before. And my mate had to go to the toilet, and I filmed him, right, Simo? I filmed him, and he was squeezing his bum cheeks, that external sphincter. He was controlling it that way. What happened to get into the toilet? There was a step, and the step was about 20 centimetres, and I got it on footage. I got it on footage. He had to essentially relax his external sphincter to get up. And it's funny because he's one of my best mates. And I got on video. The moment that he took the step was the moment that he still couldn't contract the external sphincter, and that was in the moment on the video that his hand went to his bum, and the poor dude in Munich. Anyway, so back to the educational part. Love you, H. Back to the educational part, because my mind went, is one of the strategies back to urinary incontinence, I need to do a wee a lot. So is it a valid strategy to say, you know what, I need to do a wee, but I'm going to train my body, I'm going to hold on to it? Or, because sometimes with women, there's a UTI, a urinary tract infection, so that there's this balancing point. Could you speak to that?
So you do, so often people get into the habit of going to the toilet, like, well, I'll have a wee just in case. And that you preemptive wee. And so the bladder itself is kind of a muscular system, and it responds to stretch in the same way. So you start filling up, and the body goes, oh, I think I need a wee, and then you can turn that off. And as it gets more fuller and fuller, it goes, okay, now I really need a wee. Now I really need a wee.
Blowing up like a balloon, isn't it?
But the problem comes if you never let it fill properly, it behaves as if it's much smaller. So it will feel a stretch to urinate sort of when it it's less full, and so you're like, oh no, I need to go now, when you don't really need to go. You just have a bladder that just doesn't know what its length is anymore, because you've never allowed it to fill. So stopping yourself going isn't a bad thing, as long as it's not chronically, and you're just not doing it all the time. It's like, well, I can't get off this desk, I've got to keep working, I've got to hold it. And you do that every day, and then you irritate the bladder, so you can get sort of an overactive bladder then, that just starts to sort of give you signals of wanting to go all the time. So you get your urge incontinence, and your stress incontinence and things like that. So you sometimes feel you want to go, and you get there and you can't go, or you that's your kind of your urge incontinence, and then your stress incontinence is like, no, I really do need to go now. And then you just pee more frequently, and whether that's related to your prostate or whether that's related to your bladder are different things. But when it's bladder, you don't want anything that irritates your bladder to occur. So you don't want a bladder that is feels it's too small, and then you load on it lots of caffeine, which is for some people an irritant. We used to think it was an irritant for everyone. It's not. It seems to not necessarily be an irritant for a lot of people, but certain alcoholic drinks are. So like the guy I was talking about before, his was whiskey, and he found that would trigger him a lot. And so you want a bladder that is able to receive a decent capacity, and then you're able to empty it when you need to. And if you hold it for a little bit longer, it doesn't matter, as long as you're not doing that all the time.
Well, have green tea? Green tea comes up consistently via research as something that can potentially alleviate the incidence of prostate cancer. Green tea comes up quite a lot.
It is an antioxidant, isn't it?
Yeah. But also it seems to make you want to do a wee.
It does. It's a bladder irritant.
So you're like, oh, come on.
Yeah.
But that's one thing that does come up regularly, green tea, regular drinking of green tea. And then another one that comes up, because you touched on low dose or Cialis, which effectively is an extended Viagra, which came from the research, I think it was 1998, the Nobel Prize for nitric oxide came out with Louis Ignarro and his other mates. And then, because I remember pre-workouts, we used to, I probably still do, I just don't use them, but I had a period of time, and bro science, lots of men do, and women, people in the gym do, L-citrulline, which is high in watermelon. And we used to call I don't know if they still do or not, but do you ever hear watermelon was natural Viagra? So we used dudes in Tamworth, Australia, and in Newcastle, Australia, and Burleigh Heads, Australia, the places that I lived, used to believe that if you eat a lot of watermelon, high levels of L-citrulline. Turns out it's more in the white part of the watermelon. So you've got to eat the red and the white. Was a good pre-workout because it's a vasodilator. And as a result of being a vasodilator, we made a connection to say that you might indeed get a stiffy and erection as a result of watermelon, and so we called it nature's Viagra. I don't even know how that stood up. That could indeed be
Tamworth research.
I'm actually going back there next week. I'll see you there. We'll get on the watermelon. But I don't know how valid. What is valid is that in this seemingly invalid conversation is that watermelon is high in L-citrulline, which is an amino acid that works as a vasodilator. So there is some sense in there, and it's not bad for you. Get into it, people.
I have to say, men, we will do anything to accept the right things, it would seem.
Yeah, bro science.
We'll
do good and bad.
Like, we want better erections, we want to go for longer, we want to shoot further. So we'll do all of these things to try, if you look at Chinese medicine and, the things I'll do to kind of keep your erection going. When the solutions are fairly straightforward, they are like, don't be overweight, take care of your fitness, and have a pelvic floor that works really well, and keep stronger as you get older, lift weights.
Eat well.
Yeah.
Breathe well. We've established that. Breathe well.
So there are. I think the problem that things that go wrong for us is these simple solutions or these simple interventions. We aren't good at them anymore. We don't sleep enough. We eat the wrong foods. We eat at the wrong times. We don't work with the cycles of nature anymore. We kind of force our will upon nature. So we're staying up really late. We're not sort of getting enough recovery. And so all of these things are stress additives. So we know that, stress has a cumulative effect. It doesn't matter whether it's physical, psychological, spiritual, emotional, that you only have a certain amount of stress you can deal with, and either you have to reduce the burden of stress or you try and build your resilience up, which is what we know exercise does. So, I think that we're getting a lot more of these problems simply because we just don't live very well anymore.
And then almost to the point that I was speaking about the green tea and the watermelon, we gravitate towards, well, you know what? Okay, I'm going to neglect myself,
Yes.
my sleep.
But I want a quick fix.
But you know what? I'm going to eat watermelon and drink green tea, and I'm going to be okay.
The amount of young men now taking Viagra or Cialis is staggering.
And that's a sad indictment of modern society.
But they're not taking it because they need to. They're taking it because of performance anxiety as well. What if I can't? So I remember I had to go to Canada recently and I was catching up with some friends, and I was just asked, can I get any Cialis or Viagra to take with me for them? Because they couldn't get it on prescription there. Whereas some of the pharmacies in Hong Kong are a little bit lax with their sales practices. And they just wanted, and I said, well, you're having problems? Like, no, but I always want to have a good, solid erection. Like, well, you could do other things for that. You could do Kegel exercises or the equivalent for guys.
All right, mate, I feel we've come to a natural conclusion in this conversation, but...
We've reached the climax.
I know. Oh, hello. I feel pretty good for doing those exercises, and I was doing some breathing, so I've had a pretty awesome pelvic floor workout. What would you leave? There's a few things that I reflect on this conversation. One of them that I really like is I need to be more open to talking about my problems, and I need to, if I can, seek help.
Yeah.
And I understand that resources come up, money comes up, but there are avenues where you can find help that don't cost a lot of money. If you don't have great insurance, you please find them, because if you don't find them now, you're going to really need to find them later on down the track, and the sort of exponentially might be more use of your resources.
There are lots of, and certainly we can provide links to resources for people to get information. But I think men need to find someone to talk to. They need a buddy. They need a friend that they can sort of open up to, or a group of people that they can open up to. And just to touch back on one thing that we said earlier when we were talking about sort of the Movember and the Men's Health Month, it's all very well doing it that month, but it would be better to do it all year round, was that one of the HR directors said that every November she tries to set up a men's only support group in that month. And she's always blocked from doing it because they say everything has to be inclusive now. And one of the doctors on the panel said, but maybe people with a prostate gland want to talk to other people with a prostate gland. And it's not like we're going to cigar bars and looking at pin-ups. Men need other men to talk to, and we will never normalize it until we can create some safe spaces for men to meet together, and sort of passing that into a broader discussion, not for now, but men and masculinity. What does that mean now? And if our identity and our sex education, which came from pornography, is wrapped up in how we perform, what does that say about our society where that is our image of masculinity? And it should focus more on a father providing for his family, or a guy having self-discipline to do something, or integrity, and all of the things that we've lost. They're just the words that have just disappeared from our vocabulary because we look at masculinity in a very particular way. Whereas maybe if the guys just got together and just talked about stuff and someone facilitated it, it would just be very different.
And even to one of your points earlier, even if it's not facilitated, if you're doing it in a relaxed way where it brings a bit of jest, your mates are just
like this guy, this Australian
your mates
dude.
are just taking the piss. One more story from me.
Not taking the piss.
One of my mates, it's okay because he did have kids, but one of my mates was having trouble having children, and so him and his wife did some testing, and anyway, it turned up that his sperm was slow swimmers or something was going on. So prior to having sex, where they were going to try to have a baby, my mate had to dangle his nuts in ice. So he said that it'd be great and they'd be excited. And then you spoke about the pressure, but he'd be excited. And then he was like, hang on, babe, let's get the ice. And so he'd dip his boys in ice, and then everything would go the wrong way. Anyway, he started talking to us about this, which was funny as hell. But what that did as a result, because then he started joking with his wife about the pressure dissipated, and actually they turned it into a sort of a game. And the result came out okay. But not until, here's the power of just, you know, in Australia we say drink some beers and tell some lies. And what that means is me and you, Simo, let's go on a Friday, we'll go have a couple of beers and we'll just unwind and talk, and we might even conflate and exaggerate stories, but it doesn't matter. Drink some beers, tell some lies, that's therapeutic.
Yep.
It wasn't until he drank some beers and told us about this that we all started messing around and joking, that he took that into the bedroom where his wife, and then it became a game.
Yeah.
And thankfully it worked out well for him. But it seems as though that congruent thread of bringing it into the light in the right context around the right people, of course, seems to be very therapeutic across the board.
I think there's no downside in having conversations or finding people that you're comfortable with to talk to.
Yeah.
And then, you know, you suddenly realise that somebody else has got a similar issue or a different issue, but they feel just as embarrassed about that, or their ability to perform is declining. And so that, you know, this idea of like misery loves company, like we're like talking about it. I think for guys, we're just not programmed genetically to have a conversation about something unless we feel there's a payoff for it. Has to be, we're solutions driven. So like, I will tell this person because I will get help back. I can't put up this shelf, so I'll tell my friend, and I know he will help me put the shelf up, or he will do it for me. And it's the same thing. It's like we won't just talk about things for the sake of talking about things.
The transfer of information must be practical.
Yes, 100%.
Yeah.
But if we can talk about things, you'll find that everyone's problems. And the biggest takeaway I have from a male pelvic health is that I assumed when I got into this, I would be dealing with post-prostatectomy patients most of the time. I have only one patient who is over 40 years old.
Oh, really?
Yeah.
Wow.
Yeah.
That's valuable work you're doing,
Yeah.
mate. I got a good feeling for you just then. And our company, Joint Dynamics.
Excellent.
So if you do want some more information, ladies and gentlemen.
And some good feelings.
Yeah, and some good feelings. And I say ladies because if you're seeing some change with your man, then he's not going to do anything. Maybe you could take the reins in this example and do something about it. But reach out to us at Joint Dynamics. Simo here is a plethora of information and happy to share.
I'm happy to jump on a call with anyone, just chat things through.
Yeah, we're in Hong Kong, of course, so there might be some geographical limitations, but we're always here for you. And, mate, I hope that this podcast was helpful to you guys as it was to me. I learned some cool stuff.
Cool.
Had a great time too, Simo.
Great fun.
And again, thank you very much to Monday Studios for letting us come here. This is a great studio.
The best.
I don't even know. This drink is sort of like a stimulant, as is Mu Vitality Mushrooms. But you know what? Do us a favour, everyone, as I do some shameless plugs. Would you mind subscribing? Tell your mates about this podcast. Comes out every 2 weeks. Some amazing people, such as my mate Simo, who's the CEO of Joint Dynamics, and many others on men's health, on world champions, on all that stuff that I find really interesting that I believe will be valuable for you. Until next 2 weeks, see you later. See you, Simo.
Cheers.